System. Good. So the background is it live now? It is live. It is live. Nobody will be there. We said 5. It's a little pain. Good evening, friends, and welcome to the live webinar hosted by SP Medifort Hospital, Trivandrum. This is part of our educational activity and outreach educational program which we conduct periodically. Before we start, let me introduce myself. I am Dr. Girish Menon, Senior Consultant Neurosurgeon here at SP Medifort, with over 3.5 decades of experience in the field of neurosurgery. I used to be a Senior Consultant Professor at Sree Chitra Tirunal Institute. Then I had a long tenure at Silver Medical College, Manipal, before moving on to SP Medifort Hospital here at Trivandrum. Now, stroke is one of the most leading causes for death and disability globally. It's the disability part of the stroke which is more worrisome and leaves not only the family, not only the patient, but the entire family in a devastated mode. Treatment for stroke is essentially preventive, and the role for surgery is minimal. But nevertheless, surgeons do have a significant role in selected cases and selected scenarios. And that is what I would be trying to highlight in the next half an hour or so. Before going over to that, I just wish to share with some painful inputs about this worrisome entity called stroke. If you look at it, compared to what happens in the West, the incidence of stroke is increasing in India. And the painful truth is that more and more young people are getting affected. So if you look at the age group of stroke, especially brain hemorrhages, as you popularly call it, the incidence is in the late 70s or mid 70s in the West. In India, it is in the late 50s. So more and more younger people getting affected, and more so in India. And as I said, the best part of it is preventive, and that's what I would wish to highlight in the next couple of minutes, in the next half an hour or so. So just to give a background of what is stroke, and I understand that it's a mixed crowd that is watching this webinar, so I like to be, and many non-medicals watching, so I would like to be as simple as possible for the sake of clarity and brevity. So here you see the heart, which pumps around 750 to 1 liter of blood every minute to the brain. And each time the heart pumps blood, the pure blood goes through this kind of pipes, which I shall be calling arteries in my conversation. So now, when does a stroke happen? When this pipe gets blocked, as it's shown here, or when this pipe called the artery bursts. So these are the two kinds of stroke which can happen. The pipe will either get blocked. The pipe, I mean the artery which carries blood from the heart to the brain. The pipe will either get blocked or it will rupture and cause a hemorrhage. So to make it more simple, so these are illustrative pictures. Here you can see this is the pipe which carries blood. It is dividing into two arteries. One of the arteries is fine, blood is flowing through this artery, but there is a small piece of what we call as an embolus or a thrombus, which is blocking the pipe here. And you can see this part of the brain is looking pink and pink, whereas this part of the brain is becoming bluish because of lack of blood flow. And this is what happens if we do an autopsy of such patients. You can see this part of the brain, which is dead because of lack of blood supply. And why is this lack of blood supply happening? Because the part of the artery which carries blood to that brain has got blocked. And this kind of stroke, we call it as ischemic stroke. And what is the other kind of stroke? You can see here, it is so illustrative. You can see the pipe is burst. And here, if you do an autopsy of a brain of such patients, you will see a large blood clot inside the brain. So this is hemorrhagic stroke and this is ischemic stroke. Now, if we have 100 patients with stroke, 70 to 80 of them would belong to this category, that is ischemic stroke, and only 10 to 20 would belong to this hemorrhagic stroke category. Ischemic stroke is a more common variety that you see, and it is essentially managed by neurophysicians, whereas hemorrhagic stroke is managed by neurosurgeons predominantly. But there are some instances of ischemic stroke where the surgeon also comes into play. So those are the instances which I would like to highlight. So the role of surgery is limited, but it is definite in certain instances, especially two. When there is a well-established stroke and the patient is going to die, we have a surgery which I will be explaining. It is a life-saving surgery. And then in patients who are having recurrent episodes of minor strokes, we have another procedure, few procedures which will help prevent having further strokes. Now, first let us go around, start with ischemic stroke, which as I said is a more common variety. As I showed here, this artery is getting blocked. And when this happens, what happens? You wake up from sleep or while you're active, suddenly the patient comes with history of sudden onset weakness of one side of the body. The face gets angled to one side, speech disappears, and such similar symptoms can happen. And the management in such instances is essentially thrombolysis. And what do you mean by thrombolysis? You give medicines which will go act here and dissolve this clot so that blood flow is restored. But better than that is this new technique which is now popular and commonly done in all centers, including ours. This technique called mechanical thrombectomy, where you have certain gadgets. You take the patient, rush the patient to a cath lab, and you put this kind of wires inside the artery and they grasp this clot and remove it. So this technique of removing it mechanically is called mechanical thrombectomy. And initially we try to dissolve them with giving medicines, and that is called thrombolysis. But in all this scenario, this by say by far is the standard of care in ischemic stroke. But the catch is that the patient should reach the hospital early. So if you reach the hospital early, within 3 hours of the symptoms, the symptoms which I told is one part of the body getting weak, face getting twisted to one side, inability to speak. And if we reach the hospital within 3 hours, there's a good chance that the doctors would be able to clear this block and, and restore blood supply to the brain and prevent further damage. Now, let us see some scenarios where a surgeon can come into play. So there is this example of a 70-year-old patient who is a known hypertensive, and he presented with sudden onset of weakness of one half of the body 20 days back, and he recovered from that spontaneously. So what does generally people do? It was some kind of weakness and the patient has recovered. So generally they ignore, but this patient did not. He reached the hospital. We did few tests. The most important of them, as I've written here, is called the carotid Doppler. And you can see what the carotid Doppler shows on the right side. You can see everything is good, but in the left side, you see the pipes. So these are the pipes. Carotid Doppler is carotid is an artery or a pipe which carries blood from the heart to the brain. You can see that this pipe is blocked. There are a lot of debris inside. This is just like what happens to our house. The pipe which carries water to the house, sometimes you can see when you open the pipe after many years, you will see a lot of debris inside that which clogs the pipe. So same way, this happened in this gentleman. We confirmed it by doing an angiogram, and you can see this pipe on this side, the artery on this side is so good and patent. You can see the artery on this side is so thin and like a pencil. Again, reconfirmed using another gold standard called an angiogram, and you can see what is happening here. This part of the artery looks fine, but here you can see it is all narrow because of this clot inside or debris inside the artery. So in such scenarios, we surgeons do a surgery called carotid endarterectomy, and this is what I am showing here. You can see this is an artery here. This is the small opening is made in the neck, and you can find that this artery is called the carotid artery. It is dividing into two. Then we open it is just like plumbing work. We open the artery, we open the pipe, and you see what you find inside. So we call it atheroma, which is blocking the carotid arteries. So we gently peel it off. So this entire thing was blocking the artery and thereby blocking the blood supply to the brain. So what we do is we open it, remove that block, clear it up, and then suture it back. And this technique which we surgeons do, we call it as carotid endarterectomy. So this, as you can simply see, is just cleaning up the pipe or the artery which carries blood to the brain. And by doing this, we can prevent that patient from having further strokes. So this is one preventive surgery which can be done in patients who have minor stroke. So you see a patient who has had a minor stroke has a risk of having a major stroke later on. This patient fortunately recovered after the first stroke. He came to the doctor promptly. We could find where the problem was, and then we could remove that. And this is what we found after removing. So all the burgers, the pizzas, and the cheese, and all that unhealthy junk food which we eat, we should remember they all come and get collected in these arteries, and slowly over the years they block blood circulation to the brain, and that is how stroke happens. And you see what happened after the surgery. When we do a Doppler, you find that the passage to the brain has opened up and all that is clear. And this patient never had any more strokes after that. Now look at this girl, the small young girl who had presented recently to us from Madhya Pradesh. She had recurrent episodes of stammering or stuttering or speech blockade. And then she had weakness also, right and left side. We got some scans done, and you can see this is the MRI of the brain. This is the right side, this is the left side. And you can see there is this is a normal brain which looks grayish to black, and this brain looks whitish. This suggests that this part of the brain is damaged. And when we do an angiogram, you can see the main arteries to the brain as all not seen at all totally. So the main pipes which carry blood to the brain, the carotid arteries and its branches, what has happened? They've all shut down over the years. They are not seen, and in their place, nature has given some compensatory mechanism. So instead of the large, big pipes, multiple small pipes have come and trying to compensate for the lack of blood supply because of the obliteration of the large arteries. And this is another example of this is not a child, this is a 42-year-old gentleman who you can see this is a CT scan of the brain, and in this the gray is thing which is seen is the brain, and the white thing seen inside the scan is the blood clot. So this gentleman, unlike the other child who had a damage because of lack of blood supply, this gentleman had a bleed inside the brain. But the angiogram, when we did for both patients, we had similar findings. So what had happened was, as I said, the large arteries had kind of got obliterated, and instead small multiple arteries had formed in their place, and these arteries were for some reason not able to cope up with the need for the blood requirement for the brain. So in that child, what happened? The child had an ischemic stroke, whereas this gentleman had an hemorrhagic stroke. And now this condition is called Moya disease, where what exactly happens is, as I said, the large arteries get obliterated, disappear, and in their place, small arteries come, and these arteries on the MR on an angiogram appear like a puff of smoke. So this is a Japanese word. Moya means a puff of smoke is a Japanese word. And in such instances also, a surgeon can do a great job. What we try to do is we increase the blood size. So there is a lack of, as I said, the main pipes have disappeared. Small multiple pipes or arteries are trying to, capillaries are trying to compensate, but the compensatory mechanism is not enough. Surprisingly, in such patients, the arteries which supply blood to the skin and the muscles that is outside the skull, they remain normal. So this disease primarily affects the large arteries inside the brain. The arteries outside in the skin and the muscles are all normal. So what we do is we take a artery from the muscle and we connect it to the artery inside the brain. So this is called a bypass surgery in our terminology. It is called so the artery outside is the superficial temporal artery, and now we have the first artery which I showed was an artery in the skin or the muscle, and now we have opened the brain. This is an artery inside the brain, and what we do is the normal artery outside we connect it, we suture it to this artery inside the brain. So what we are trying to do is increase the blood circulation to the inside of the brain by using a normal artery which is supplying part of the skin and the muscles outside. So the skin and the muscles outside have multiple supply from other sources. So by taking one artery from there does not cause much damage, whereas the brain badly needs more blood supply in this condition called Moya Moya disease. So this is a surgery for a Moya Moya disease. We call it cerebral revascularization surgery. So this is another instance of ischemic stroke where a surgeon can help prevent further strokes in both in children as well as in adults. Fortunately, this condition called Moya Moya is not very common. It is more common in Japan, China, and so forth. But in India, we are realizing and we are finding more and more patients with this condition. Now, this, as I said, is called a bypass procedure, and it is done in conditions like Moya Moya disease and sometimes conditions called intracranial atherosclerosis. I showed you a scenario earlier where the artery in the neck was blocked and clotted. The same thing can happen inside the brain. And in such instances, we do not open and clear it, but we do this surgery called the bypass surgery. Now, let us look at this patient, a 54-year-old lady. She presented with bleeding from the nose. And when we did an angiogram, we found that so this you can see, these are the normal artery or the pipes which carry blood to the brain. But here everyone can see there's a large balloon-like dilatation. So one of the pipes or the arteries which carry blood to the brain had bulged out like an aneurysm, and this was causing bleeding. In such instances, it becomes to save life, we will have to sacrifice this artery. This pipe has to be blocked. So what happens when this pipe or artery is blocked? That half of the brain will not. So if I block it here, this part of the brain, this arteries and all will not get blood because we have blocked it. So in such scenarios, we do another bypass. So the first earlier bypass surgery, which I showed, is called a low flow bypass surgery. But in this instance, what we do is a high flow bypass. You would have heard what coronary or cardiac surgeons do in the heart. They take a vein from the leg and use it to do bypass. So we do the same. We take the vein from the leg and then we suture it to the brain. So the one part of that vein is connected to the artery in the neck, and the other part is connected to the artery inside the brain. And the part of the artery which has that balloon-like aneurysm is clipped and obliterated so that there is no blood flowing into that artery and there is no risk of having a bleed or a brain hemorrhage. So this surgery is called a high flow bypass surgery, whereas the previous one which we did was a low flow bypass surgery. So in this, what we have done is we have taken a vein from the leg, connected it to the artery in the neck, and the other end we have connected to the artery inside the brain so that the blood circulation to the brain is not affected when we block that aneurysm. So this is how it looks at the end of the surgery. So these are high flow bypass surgeries. So now all the surgeries which I told were patients who had symptoms but they recovered, and we were doing this procedure to prevent the symptoms from recurring. But now what happens if the patient has a large or a well-established stroke? So you can see two to three instances where you have one, this is the left half of the brain, there's the right half. You can see this gray is the normal brain, this black is the brain which is dead or damaged because there is no blood circulation. This is the part of the another example of a scan. You can see all totally black, this part of the brain called the cerebellum. And there's another example of a damaged brain because the artery, or it's not an artery, but a vein which carries impure blood from the brain has got blocked or damaged. So in such scenarios, what happens is when the brain loses blood supply and the brain gets damaged, we call it as an infarcted brain. And an infarcted brain or a damaged brain tries to swell up. So just imagine if your hand or a forearm has a fracture. So there is the injury there, and the forearm can swell, it keeps swelling. And there's nothing that prevents the hand or arm from swelling because there is nothing blocking it. But here inside the bone is such a rigid structure, it will not allow the brain to expand. So this part of the brain is damaged, it wants to expand. The skull does not allow it to expand. But when it keeps expanding, it presses on the normal brain also, the entire brain gets damaged. So in such scenarios, we do a surgery called decompressive craniectomy. It is a very simple surgery, but a life-saving surgery. We take out a large half of the skull, and we just allow the brain to expand. We take it out and close the skin alone. You can see this half, how that part is sunken after some time. So it will allow the brain to expand. After 2 or 3 weeks, the swelling comes down, and after a month or so, we put the bone back. So this surgery is called decompressive craniectomy, and it helps. It's a life-saving surgery in patients with large infarct or large strokes, because the damaged brain because of the stroke is expanding. It becomes life-threatening, and we do that to save life. And studies have shown that it not only saves life, in many instances, especially if the stroke is on the right side, patients get back to near normal activity. So to summarize, I was talking about ischemic stroke. Those are strokes where blood supply to the brain is affected because arteries or veins to the brain get blocked. So we have three types of surgeries. One I showed here is called endarterectomy, where we take out the clot inside the artery in the neck. Then we have revascularization surgeries called bypass surgeries. And as I showed that other lady with a large aneurysm, so these are all preventive surgeries to prevent further stroke from happening. And when a large stroke happens, we do this surgery called decompressive craniectomy. So these are the roles of the surgeon in case of ischemic stroke. Now let us look at this scenario where you have a 54-year-old gentleman who is a smoker and an alcoholic. He has high blood pressure but does not take medicines regularly, and suddenly one day you find that he is unconscious and drowsy, his blood pressure is very high, he has one side weakness, he is comatose. You do a scan for such patients, you will find one of the three types of scan. You can see again, this outside white thing is the skull in all this, the brain is gray, and again white inside. So anything white on a CT scan is either brain or blood, in either bone or blood. So you can see a large amount of large blood clot inside the brain. Here you can see streaks of white, streaks of blood inside the brain. This is a small clot again inside the brain. So these are instances, this kind of hemorrhage, brain hemorrhage happens because of high blood pressure. This kind of brain hemorrhage happens because of some problem inside that need not be because of high blood pressure, but some problem in the blood vessel or the artery, which I will explain later. Then we can have some other instances of brain hemorrhage because of other causes, like if there is a tumor, it can have bleed inside the tumor. Patients who are taking blood thinners or anticoagulants, medicines which prevent the blood from clotting, they all can have brain hemorrhages, but they all form very small percentage. As I said, patients, if you have 100 patients with with brain hemorrhage, 70% of them would be because of high blood pressure. Rest 20% to 30 would be because of some problem in the blood vessels or the arteries, which I will be explaining. So now this is a very common problem, hemorrhagic stroke because of high blood pressure or brain hemorrhage. And unfortunately, unlike an ischemic stroke, which I showed earlier, these patients carry very, very bad outcome. And how to manage this is a big challenge, and we still do not have answer to that. But we know for sure some points. Like if this hemorrhage is very small, like this one, we don't have to do anything. If the hemorrhage is very big like this one, there is no point doing anything because these patients do not make it. And even if they do, they will remain vegetative lifelong. So very small hemorrhages, very large hemorrhages, nothing to be done because it does not help. It is clots like this, the moderate, medium-sized clots where we have a dilemma, we are not sure what is to be done. Logic would tell us that there is a clot, you take out the clot, patients do well. But what we have realized over the years from experience is taking out the clot and giving a clean, good scan does not translate to patient recovery. A clean scan does not always mean that the patient does well. Why is it so? It's because the damage happens at the time of the bleed. The time there is a hemorrhage, there is blood clot inside the brain and surrounding brain gets damaged. After that, whatever you do, you go and take out the blood clot and all, the damage is already done. It does not help much. That is in most of the cases, except there are few instances of brain hemorrhages where surgery helps. So I was talking about those large clots, like clots in some part of the brain, which we call the cerebellum or the frontal lobe, temporal lobes, young patients, small clots. If we go and take out the clot, they do well. So now if this is the overall summary of brain hemorrhages, if you see there is clot in these two areas, it is a tick. If you go and operate and help take out and help these patients, they do well. But clots inside the critical areas of the brain called the brain stem or such large clots do not, whatever you do, they do not do well. So no role for surgery in such brain hemorrhages is limited to certain scenarios as I have shown. And here again, we have a lot of developments happening. Earlier, we used to do large openings, we used to do large surgeries. Nowadays, we do very simple keyhole surgeries to take out the clot called endoscopic surgeries. And that is the new innovation that is happening in this area of surgery for stroke. We are doing very keyholes, minimally invasive. We call keyhole endoscopic surgery to take out the clots. And such patients do well. But again, as I said, does not apply to all patients. Only few patients with brain hemorrhages merit surgery. And in such instances, if we do keyhole minimally invasive surgery, it helps. So how do we know which are the patients who are going to do, who require surgery? As I said, if the clot volume is in this range, this is that equipoise group or the confusing group. If the clot is too small, we can wait. The clot is too big, there's no point doing anything. In addition to that, we have some other parameters which will tell us which patients are going to improve. Now, as I said, if you have 100 patients with brain hemorrhage, 70% is generally due to high blood pressure, and I showed you the scans of this. 20 to 30 will be because of some problem in the pipes or the arteries called aneurysms and arteriovenous malformations. So one of the most common scenarios is an aneurysm, which I showed earlier. It is like a balloon-like projection from one of the arteries. And in such instances, we can do a surgery called clipping of the aneurysm. This is one of the surgeries which we do. You can see, here, you can see slowly. So this, you can see a small balloon-like projection here. I'm trying to, you can see this is a normal artery or normal pipe which carries blood. It is dividing into two. At this junction where it divides into two, we can see a small balloon-like projection. Now you can see I am delivering it out. Now you can see this is that balloon-like projection, and we do this surgical procedure called clipping of the aneurysm. So once we put this clip, this balloon will not bleed after that and will not cause brain hemorrhage after that. So this is one surgery which we do for aneurysms. So here again, I would like to tell you, so this is the angiogram of an aneurysm. It's a clip. There is a new technique for aneurysms, which we call them coiling. So you can see this is another aneurysm here, the balloon-like thing, and we put coils inside. So this is a non-operative technique without operation. Operation, I mean no cutting open, no blood loss. It is done just like we do stenting for cardiac patients with heart attack. The same procedure, we can go in and put in coils inside the brain. So there is a lot of debate as to clipping or coiling, which is better. But to summarize, I would say immediate effect. For immediate benefit, coiling is superior, is better, or patients prefer coiling because there is less risk. But long term, if you compare coiling and clipping, clipping would have an edge. So for immediate effect, coiling has an edge. For long term effect, coiling has an effect. But this is a matter of, for long term effect, clipping has an effect. But this is a matter of debate. And as a surgeon, as I said, I generally prefer clipping over coiling. Now, if you see another small child with 12-year-old who presented with a brain hemorrhage, and this is another condition, this happens from birth. This is another problem, and this defect in the arteries in the brain, which we call as arteriovenous malformation. And you can see this is what happens inside the brain. There's a small surgery which shows an arteriovenous malformation in the brain. And you can see this is how it looks. So there's a small bunch of pipes or arteries which are abnormal. They should not have been there. It has happened because of some problem during in the fetus, in the intrauterine stage, when the baby is developing. There is some problem in the blood vessels of the brain, and this happens. And this kind of arteriovenous malformations, as we call them, can produce brain hemorrhage or stroke. So this is one instance where surgeons can play a role. So as I said, when the blood clot is because of high blood pressure, in some instances, we surgeons have a role in taking out the blood clot. If there is an aneurysm, we can help by clipping the aneurysm. If there is an arteriovenous malformation, we can help by taking out the arteriovenous malformation. Then there is another very common condition which generally you see in elderly people. This is also general colloquial term, people will call it brain hemorrhage. This is called chronic subdural hematoma. It's very common in elderly people, especially those who are taking ecosprin. Patient would not even recollect that their head has hit somewhere. And then 1 month later, they will say present with headache and some weakness on one side. When we do a scan, you can find that this area here, what you see is liquefied clot. So this is actually brain hemorrhage, but not a bang inside the brain. This is hemorrhage between the brain and the skull. We call it subdural hemorrhage, and this is one of the most gratifying surgeries for a neurosurgeon. We just put 2 small holes and the entire blood clot is taken out and the patients do well. So amongst neurosurgery, all types of neurosurgery, this is one of the most gratifying surgeries. So to summarize my observations, early detection is the key, and early detection will happen only if the patient is educated and reaches a competent doctor. And to reach a competent doctor, you need good transportation facility, good ambulance and retrieval. As I said, all this helps works. All this treatment will help only if it is done in the correct time, ideally within 3 hours. And if you reach a good hospital, the hospital should have all the infrastructure, as I said, a cath lab, a CT scan, an MRI, and trained personnel to carry or techniques which are done according to the latest guidelines. To summarize, as I said, stroke is not treated by one doctor alone. It's a team which can help. Forget about the neurologists and the neurosurgeons. Rehabilitation, physiotherapy, speech therapy, occupational therapy, nursing care, above all this, it has to be a coordinated effort, because the damage which happens takes a long time to recover. Brain recovery does not happen in a short time. I would say the doctor's role is very minimal. It is the nurses, the physiotherapists, the occupational therapists, and speech therapists all together play important role. So to summarize, role of surgery in established stroke. If a stroke has already happened, in established stroke, as I said, in ischemic stroke, we do a surgery, life-saving surgery called decompressive craniectomy, or taking out the clot, or clipping aneurysms, or draining blood from the brain. And to prevent strokes, we can do this kind of surgeries called endarterectomies, revascularization, so forth. But most important part is prevention. No matter what you do, at the end of the day, one neuron lost is lost. It does not grow back. So the best part of stroke management is prevention. And how do you do that? Control of blood pressure, avoid heavy alcohol, smoking, regular physical activity, and like the old dictum which all of us are taught right from our school days, prevention is better than cure. And there is no other disease where it is more apt than in stroke. Thank you so much. Glad to take any comments or questions if there are any in the chat box. And I'll end it.